spread, but also lymphatic and hematogenous spread, which is often why response to systemic anti-cancer treatment isn't always uniform. We also know that primary tumor that spreads to the liver or the lung tends to be monoclonal, whereas peritoneal spread, particularly direct seeding, can retain a lot of the polyclonal nature of the primary tumor. And again, that makes it a challenge, and historically, response to systemic treatment was poor. Who gets peritoneal disease from colorectal cancer? Well, this Swedish colorectal registry data, 35,000 patients, and T4 tumors with perforation, emergency procedures, patients with lymph node involvement from their primary or liver metastasis and Krukenberg tumors, as well as right-sided cancers, are more likely to get peritoneal disease. And mucinous tumors with BRAF, KRAS, signet ring cell histological types are also more likely to spread to the peritoneum. So how did we get to where we are now? What's the evidence base for cytoreductive surgery and HIPEC? Well, this comes from a number of things: animal studies, institutional experience, systematic reviews. There was one randomized controlled trial from 2003. There are more now, but I'll just touch on some of them. This is an animal study in a mouse rat model comparing surgery alone in an animal model of peritoneal disease with mitomycin C at 15 milligrams per meter squared versus 35 milligrams per meter squared. You can see that those animals that had HIPEC as well as the surgery had significantly longer survival and less tumor load. So that's some animal studies to support the use of HIPEC with surgery. The French pooled their data. This is old data now, but over 500 patients, 23 centers, and they showed that if they could achieve a complete cytoreduction, then outcomes were good. Many of you will be familiar with the peritoneal cancer index, which was described by Paul Sugarbaker to help us quantify the extent of peritoneal disease. We know that the less disease that you have from colorectal cancer, the more likely you are to benefit. This, again, is some French data. The black line at the top are patients with the lowest PCI, so 0 to 5, have the best survival. And you can, as the PCI increases, then even if you can achieve a complete cytoreduction, those patients don't do well long term. Traditionally, we've described patients with peritoneal spread or peritoneal metastasis as peritoneal carcinomatosis, but actually what we're talking about, the patients who are going to benefit from this type of approach are those who've got very localized disease, and this is what we call resectable colorectal peritoneal metastasis. Traditionally, systemic anti-cancer treatment hasn't had great results, but the drugs that are available to us or the treatments that are available to us are improving. And with the onset of immunotherapy, the whole landscape is changing. So this is old data again, and we're probably talking about 24 to 36-month survival, if not more, with a combination of surgery and the best anti-cancer treatment. This is one of probably the first seminal randomized controlled trial from Vic Verwaal in the Netherlands back in 2003. And this was what really sparked the interest in the use of cytoreductive surgery and HIPEC. There was a marked difference in survival in patients who had cytoreductive surgery with HIPEC compared to systemic chemotherapy and palliative surgery alone. The National Institute of Health and Clinical Excellence in the UK has approved the use of cytoreductive surgery and HIPEC, but the evidence base to support it is not strong. There are very few randomized controlled trials until recently. Certainly in the last couple of years, we've seen some interesting trial data. So what's happening at the moment? Well, most of you who are interested in this field will know of Protégé 7, so the French trial which essentially randomized patients after a complete cytoreduction for colorectal peritoneal metastasis to HIPEC with oxaliplatin or no HIPEC, and both arms received systemic chemotherapy. What the trial found was essentially a much better median survival than people had expected, so good surgery in appropriately selected patients can give you good outcomes, 42 months median survival. But there was no difference between the arms in terms of HIPEC, no HIPEC, but significantly more morbidity with the high-dose oxaliplatin HIPEC for 30 minutes that the French used, and perhaps a survival benefit in that group of patients with a moderate amount of disease. Another trial from the French, which was looking at prophylactic second-look cytoreductive surgery and HIPEC in patients at high risk of developing peritoneal disease. They all had 6 months systemic chemotherapy, then randomized to follow-up, standard follow-up with CT, or the experimental arm with second look and HIPEC. Again, no survival benefit with the second look. But interestingly, and I think this just highlights some of the challenges we face in treating peritoneal disease, 52% had peritoneal disease despite normal imaging preoperatively, and 30% of the resected specimens that were thought to be cancer were not cancer. So this was scar tissue fibromatosis. So there are many challenges to identifying peritoneal disease on preoperative imaging, but also in a trial setting, it becomes very difficult to adequately randomize patients and stratify them appropriately. The HIPEC T4 trial from Alvaro Arione in Spain, Cordoba, this recently reported, this is patients with CT image T4 tumors and N0, randomized to surgery only or surgery with HIPEC using mitomycin C. And the primary outcome was 3-year local regional control. 184 patients randomized. There was a difference in local recurrence rates at 3 years, but there was no difference in overall survival or disease-free survival, which isn't surprising in that colorectal cancer is a systemic disease. And the HIPEC is focusing on the local regional recurrence, but it's not going to have any impact on systemic disease. This is our own experience with 555 patients. We just submitted and accepted for publication in Annals of Surgical Oncology. Our overall survival, 51% in patients who received a complete cytoreduction. If you had a PCI over 6 or perineural invasion or mutated KRAS status, then that impacted both your overall survival and disease-free survival. What I wanted to draw your attention to are the patterns of recurrence. And you can see here that about a third of patients will have isolated local recurrence, but about nearly 70% of patients will have either combined local and systemic or systemic recurrence. So you're not going to cure the majority of these patients. And in terms of 5-year overall survival, it's about 40% if you just had peritoneal disease, but if you had systemic disease, it's much less than that. So you've got to select these patients appropriately. You've also got to be aware that for the majority of these patients, you're not going to cure them. So where are we going? We've heard about ctDNA earlier on today, and I think that might have some promise in terms of identifying patients early who may develop peritoneal disease and then implementing appropriate treatment. The Dutch have the Cairo 6 trial, which may help us answer the question as to whether systemic treatment up front is beneficial in these patients. So these are patients with peritoneal disease randomized to either the control arm, which is surgery with HIPEC up front, or the experimental arm, because in the Netherlands now, at the moment, systemic chemotherapy isn't approved for upfront treatment. Those patients would get chemotherapy and then go on to have surgery. So it might help us answer that question as to the timing of systemic treatment in relation to cytoreductive surgery and HIPEC. And this is a Spanish trial again, where along the lines of Protégé 7, but rather than using oxaliplatin, using mitomycin C for 90 minutes versus no HIPEC, with the primary endpoint being peritoneal recurrence-free survival. And that it may be that the use of HIPEC has it most benefit in terms of reducing or delaying peritoneal recurrence, rather than improving overall survival. And we may benefit from moving away from using overall survival and disease-free survival as measures, and rather looking at obstruction-free survival when we're talking about patients with peritoneal disease. So where are we heading in the future? Well, I think earlier detection and more accurate staging. CT still is our mainstay, although we're using MRI with special protocols to help us identify low-volume small bowel serosal disease. We tend to use positive oral contrast rather, which is going out of fashion amongst radiologists, but it helps us to identify small bowel disease. I think we haven't established what the optimal timing of a systemic anti-cancer treatment is with surgery and HIPEC. Do we do it before? Do we do it after? But also, I think we need to continue to develop and refine our surgical techniques. Post-operative care is absolutely essential. You have to get these patients out of hospital safely and in an adequate time, otherwise you delay their systemic treatment, and that may jeopardize their survival. Are we using the right drugs? Probably not. Are there other ways of delivering them? People have talked about hydrogels, and we'll talk about PIPAC tomorrow. And what are the strategies for managing local and systemic recurrence after people have had CRS and HIPEC? We're also, quality of life is really important. So if we're not going to make these people live longer, we have to make them live better. But we also need to choose the right patients. And I think I just wanted to leave you with this. We're doing this really to help people to live a better life. We may not be curing them. This is one of my patients who I operated on 5 years ago. She had a right colon cancer involving the right ovary and a distal ureter. So relatively limited disease. Those medals she's holding up, every one of those is an ultra marathon. So where's Ramsay? Yeah, our marathon runners here. So an ultra marathon. So those are all the ultra marathons that she's run since she had her surgery. So really, it's just to remind us of why we're doing all of this. Thank you very much.
So it's quite intriguing to see that all this while, oxaliplatin as a systemic treatment seems to do superbly. But when you use the same drug in HIPEC, it doesn't seem to work. Is there a particular reason that you find that happens?
Yeah. Well, I mean, you've never used, I guess, systemically, you've always used oxaliplatin with another drug, haven't you? And although people give induction 5-FU and leucovorin with oxaliplatin when they use it intraperitoneally, I think we're making a lot of extrapolations between the evidence and the data we have to manage systemic disease. What we don't know is whether that's valid in terms of how we manage peritoneal disease. And I think we're way behind in our understanding, and also trials in this setting are notoriously difficult to do. So to get those numbers in order to compare one drug with another, particularly when it's a systemic disease, it's very difficult to untangle. So I'm not sure if I've answered your question, but I think, there's a lot more we need to understand.
Excellent talk. Thank you very much. The one thing I like to tell is regarding the Prodigy trial.
Yeah.
After what happened was Prodigy trial, next week after the HIPEC vendor visited me, and he was so disappointed and he was almost crying. And I also used to see Dr. Saklani when I go to Tata Memorial as an examiner. He'll be always doing HIPEC, and he's never surfaced out. But after this trial, he also reduced a bit, and he comes out very often. And how you after this trial did it made the community clever in terms of understanding and going ahead? And did you fine-tune the indications for HIPEC after this trial?
So I think one trial which was basically designed 10 years ago in a very different environment and was powered to show an 18-month difference between the no HIPEC arm, the HIPEC arm. So there are lots of, I have to say hats off to the French for doing the trial in the first place. In the UK, I sat on the committee that looked at the guidelines, and I said, look, I don't think there's enough evidence for us to stop using HIPEC. But we need to get the surgery right, so people need to choose the right patients. Selection is very important. We need to make sure people are adequately trained. The thing is, people assume, every colorectal surgeon assumes that they can do this surgery. But there are certain things you need to bear in mind with the surgery itself, but also the post-operative care, which is different to other surgical approaches. So there's some training involved. In terms of the drugs that we use, we never use, it's interesting actually, that data I presented was with mitomycin C. So we never really used oxaliplatin. We used it very briefly, but we had a lot of problems with post-operative hemorrhage. Our dose of mitomycin C is probably the lowest of anybody in the world. We use 10 milligrams per meter squared, which some people would call homeopathic. Some people would say, well, that's no HIPEC. But I guess if you've achieved a surgical complete response, what we need to find now is some method to maintain that response for as long as possible. Now, that might be HIPEC, and it may be that we just haven't found the right HIPEC drug, which we, as a community, need to work on. I think it's our responsibility to set those trials up, multi-center trials, to establish that. For colorectal cancer, as I demonstrated there, most of these patients are not going to die from local recurrence. They'll die from systemic disease or combined recurrence. So actually, we're probably focusing too much on HIPEC. We should be focusing on choosing the right patients, making sure we're all adequately trained, looking after these patients so they don't get complications, and so they can start their systemic treatment as quickly as possible.
Thank you.
Sorry, I always have this pressing question. So suppose if you were operating on someone and you found someone with PCI less than 10, maybe 6 or 7.
Yeah.
So would you give them neoadjuvant chemotherapy or would you do upfront cytoreduction? We know low PCI, 5 years survival maybe 40-45% without chemotherapy. We also know, like for profiler chip, when there was no peritoneal disease, you give 6 months chemotherapy and they still had peritoneal disease at exploration. With we also know the outcome of primary T2 cancers, if you say, is not the same as YPT2 in rectal cancer. When we look at extrapolation of Prodigy 7, you're actually having 6 months of chemotherapy and then you look at outcome of 42 months. So what my question is, even when you're looking at Cairo 6, they are not just giving chemotherapy, they are giving chemo and bevacizumab. So you can't always say for peritoneal mets from colorectal mets, you should always give neoadjuvant chemo without biological. And I have to say we do at least 3 colorectal peritoneal mets every week because I still think that's a good thing. So what do you say? Resectable, low volume PCI, less than 10, upfront or give neoadjuvant chemo?
So again, I think we talked about this before and about the trial of time biology of the disease. I guess I wouldn't be able to say, no, that's the wrong thing to do. And those patients may very well benefit from, if you can get them through safely, limited disease, and then they go on to have their systemic treatment later, because I guess most of them will have systemic treatment, then it would be difficult to argue against that. What the adjuvant treatment, if you want to call it neoadjuvant treatment or upfront systemic treatment allows you to do is just test the biology. Yeah. Are those patients going to develop liver, lung metastases? And is your treatment going to be futile, or are you going to delay their systemic treatment if they develop complications? So I wouldn't say no, that's completely wrong.
Yeah, because that's if you have low PCI and high volume center, the mobility of
is low.
Is nothing.
So you're unlikely to delay their systemic treatment. So I think it's reasonable. We may get some answers with Cairo 6, we may not.
But it has got bevacizumab.
You're right.